Welcome to another program in Medicine and Society. We're so happy to have our two guests today, Martha Montello from the University of Kansas Medical School and Docia Hickey from Levine Children's Hospital, associated with Carolinas Medical Center, and past president of the Mecklenburg County Medical Society. And both Martha and Docia specialize in the area of pediatrics in one way or another. Martha as a healthcare ethicist and humanist, and Docia as a physician. So please, I've been thinking about this topic a lot because it involves, some of the most vulnerable people in our society, little babies. And Martha, I realized that you have spent a great deal of time with parents making difficult decisions about babies that are born in ways they didn't want them to be born. They're born low birth weight. They're born with various mental or physical disabilities. Some of them can even be born with a devastating condition like Tay-Sachs disease, and there's no future for that particular baby, or even conditions like anencephaly. When parents are met with that type of event, how do you help them from a moral point of view, from a human point of view, come to terms with what the best thing to do for their child is, whether to pursue aggressive treatment or whether to let their child go?
It's a good question, Rosie. I think for me, for the last 8 years, I was chairing a pediatric ethics committee at our hospital in Kansas City. I think I've learned that some of the most important ways you can help parents going through really hard decisions and hard times is to listen. Some of the most important work of clinical ethics, I think, is in listening, because many times parents are making very hard choices that in terms of loss, and it can be really helpful to remember that parents and families that are going through really hard decisions about babies are suffering what you could call a rupture in their lives. The story of their lives, as they always thought it would go, has been broken.
They thought they were going to have a happy ending.
Mm-hmm. Absolutely. Their lives will never be the same. One pediatrician I know from Boston calls it day one. He says that it's the day a child is diagnosed with cystic fibrosis or hypoplastic left heart or cancer or is born prematurely, and it's the day that the family's life changes forever. The life they imagined having for their family is gone, and they're going to have to find some other way of going on with their lives. Aristotle called it, is a great word for it, peripeteia. It comes out of the Greek, and it means the sudden intrusion of the unexpected in our lives. But helping family to make treatment decisions or the decision to stop treatment really requires, I think, in the beginning, listening to them, understanding what they've understood to be the story of their lives until this day one happened, until this moment happened. I think that's one of our biggest challenges as clinical ethics ethicists.
I can really understand that, because you're dealing with people who had all their hopes and expectations so high, and now they have to come to terms with a new kind of life, maybe a more difficult kind of life.
Yes.
With certain types of challenges, or a life with a very sad ending in this particular chapter. Docia, you're legendary in Charlotte, and what you're legendary for are these 24-hour stints that you do at Levine Children's Hospital. As a matter of fact, you just came off of one. And what I can't help wondering is, why? Why are there 24-hour marathon sessions for neonatologists, and how do you maintain your energy and during that period of time? I know it has to be something more than coffee or, you know, illegal substances of some type or another. But how do you do it, and why is that structured that way?
It's structured that way mainly because of number of people you have working. We also have to be sure that that there is someone there. Neonatology is the intensive care nursery in the hospital. We take care of the sickest babies. But we also want to be sure we have a senior person in that unit because of that. In that respect, I have a lot of help with me when I'm doing that shift. I have neonatal nurse practitioners who are nurses who've taken extra training who are there to help me, my peds residents, and I depend heavily on my nurses in the unit. And whenever I get a chance, I go lay down. I put my feet up, I sit down, I go hide in my office and relax if I can. And that's what keeps you going. The other thing that keeps you going is the fact this is something that's extremely important. And I feel very strongly that we need to be there and we need to take the best possible care of these babies.
Yeah, I could see that it's largely commitment or passion and energy that comes from that belief. And it must really be difficult sometimes for you.
Sometimes it is. It's the hardest job you could ever want to have to do.
Yes.
And you have to love it. And you have to want to do it, and you have to believe in what you're doing.
Yes. Martha, you know, I was thinking just on the lines that you were commenting on before in terms of your role as a chair of a pediatric ethics committee. I think it'd be useful for people listening to our presentation today to know what a pediatric ethics committee is and the kind of people who are on it, and maybe some of the cases or kinds of cases that come to it. Could you share that with our audience?
Yeah, sure. The Pediatric Ethics Committee, I think at the University of Kansas, is similar to one I was on in Boston in terms of its makeup. Generally, an ethics committee, any ethics committee, tries to be what they call multidisciplinary, so that we have people from different areas of the hospital doing different kinds of work. In pediatrics, that means we're going to have pediatricians, a neonatologist. We'll try to get a neonatologist on the committee, a respiratory therapist. We'll try to have several nurses, someone from pediatric psych should be there. We'll sometimes have somebody from risk management, but not too often. Occasionally they'll visit. We also have always had, and most ethics committees, and certainly in pediatrics, very valuable, have a family member who has lost a child in that hospital. So they have had a deep experience with the workings of that hospital and are there to help things be better. So we try to have a lot of different kinds of people there, and my training is in literature. I also have an appointment in pediatrics because I've been working in that area so long. So we have people who come from very different backgrounds, and also a hospital chaplain. We do try to have a chaplain in there, and if possible to have people from a different faith, so a couple of chaplains, a rabbi if we can, whatever we have access to in the hospital. In terms of the kinds of cases that come, you get very different kinds of cases from the Adult Ethics Committee, certainly, because they involve whole families in ways they don't with the Adult Ethics Committee, and most of the time it's the parents speaking for their children. In the Adult Ethics Committees, often patients are able to speak for themselves. Not true with pediatrics. But the cases that we get, I think if there's one theme, it's this theme of rupture that I talked about, of brokenness. There's something tragic that has happened, certainly with the child. We don't have children expecting something to be terribly wrong. We expect lives to go on peacefully with one generation following another. But in pediatrics, there is this aspect of loss and brokenness. One of the cases that we had taught me...
a really hard one.
This was one of the hardest ones, I think, we've ever had. Was not that long ago, and it was a couple who The case was actually brought by a physician who was a pediatrician who was very angry with the family for what they wanted, were asking the hospital to do. They wanted surgery performed on their 12-year-old daughter, who was epileptic and had multiple seizure problems, and also had different behavioral problems. And they wanted surgery to have her have a hysterectomy so that she could not get pregnant. They were worried what her life would be like once she went past puberty. And the physicians I think it's just terrible what these parents want to do, inflict surgery on their 12-year-old daughter. The prognosis, they understood, was not good for her life ever being any different. She would never be able to live on her own. She would never be able to marry and have a real family. At the same time, to take away, a part of her body permanently, and they were using words like disfigure her, and the mood around the ethics table was very angry on the part of the doctors. I learned an enormous lesson when we brought in the voice of the parents, because when listening to the doctors, you would feel their moral passion and their caring for this patient and the 12-year-old. But then we sat down a week later with the parents, and they even brought in a video of their daughter and had filmed what sounded like it was, when they told the story and looked like it was, a typical evening after supper in their house with their other two children and this daughter. It was, oh my goodness, chaos in that house. The parents were trying very hard to keep things under control, but this daughter is very disruptive. You can tell they love her, and everybody's trying, and there's a long history of the family trying to work together. But we hadn't gotten a sense until we listened to these parents describe what their lives are like and how hard they work and how much they love this child. We hadn't gotten a sympathetic sense of what it meant to the family to work with this child. What impressed me and what I learned was, if you bring in different voices in an ethics case, a tough case, where people are colliding in their views of things, you can often develop a compassion that helps things resolve more easily. It was a deep lesson, I think, to learn. I learned it actually fairly recently, but although I'd seen signs of it before. But these parents really brought this to the fore.
Docia, along the same lines, I know you deal on the front line with parents in difficult situations and so on, especially with neonates. Did you ever find yourself in a position of really not knowing what the best thing to do for a baby is, and parents kind of looking to you to make a decision for them? And how do you handle that?
That happens, excuse me, that happens a lot. We have very difficult things go on constantly. Mm-hmm. And one of the biggest issues gets to be, as Martha is saying, it's the disruption of the family life. And this baby lived and did very well, but I'll always remember one mother looking at me who had come in. Her water broke 12 weeks early.
Oh
she said, gosh. I'm sitting there watching. Well, that actually right now is a bigger baby for us. 28 weeks is not it.
Really?
Yeah, that baby should do well.
Yeah.
And she's sitting there saying, I'm watching TV, my water breaks, I come to the hospital, I expect y'all to be able to, and she really in her heart didn't think this would happen. Give me a pill, I can go home tonight and everything will be okay. And she said, 4 hours later, I've got a baby in the intensive care nursery.
How big was that baby?
This baby was about a 2-pounder.
2 pounds.
Yeah. And she's done very well and should do well. But, but that's the disruption. I mean, your life is totally disrupted. Probably the hardest thing is the babies we know who could survive, but survive for a shorter period of time, but who have a horrible prognosis. Especially our very small babies who've had devastating bleeding in the brain, to where we know that they are going to have severe mental retardation and severe cerebral palsy. And what you do tell the parents that, but the problem is if you've got someone who has tried to get pregnant, fertility problems, and they want everything done, and you have to give them their options and give them the chance to decide. But you know what that's going to do to their family life and to their lives for the rest of that child's life and for the rest of their life. It's a very hard thing to follow.
Yeah, I'd like to hear more about that because do you feel conflicted? Let's say the parents are demanding that everything be done for the baby that's conceivable, possible. I remember a long time ago reading something called The Slow Death of Baby Andrew. Maybe one or the other of you remember that. And it was treatment turning into torture for a while it seemed to me like, in terms of the number of invasive procedures that were done on the infant, in terms of needles and prickings, and because if you show me a needle, I can't take the sight of a needle.
We have gotten a lot better, because I've been doing this for 30 years.
30?
Yeah. No, yes, I have. But of being very conscious of pain now, than where we used to not be.
Right. I think that at one time, some medical practitioners believed that babies didn't even feel pain.
And they would do surgery with just without any anesthetic. And we don't do that now. And we give pain meds, and we are very cautious of this and being careful with that. But you still are doing a lot of procedures for these children to survive. And that's the hardest, that we know that but the parents, that you have to be able to try to get it across to them. And what you do is you give them their options. You tell them this is what it is, and you try to be very honest. I usually look the parents straight in the face and go, I want you to hear what I'm saying. I'm not being mean, but you need to know the truth. This is your baby. And I'm going to tell you what's going on, and then these are your options, and we're here to support you with what you want to do.
Well, that must be...
And we can change.
And we can change.
And
I think that's
a
really good point to make, and we can change. Just because you initially say X doesn't mean we're going to think less of you if you decide, not to go ahead. This is a really great conversation to me. I'm learning a lot about what the lives of both of you must be, being able to meet these difficult cases one after the other. Martha, you mentioned your background is in literature, and I know that you work with physicians and nurses to use literature and poetry, journal writing, to help them develop empathetic skills. How does literature play a role in medicine? I mean, how does it make doctors better?
Right. Oh, how does it make people better? I don't think it makes people or doctors better. I think one thing it does, though, and the way we use it in medical schools, both with faculty, medical school faculty and physicians, and a lot with medical students, is to kind of hone the skill of entering another person's life. Every time we read a story, a really well-written story, we enter another person's life, and I think literature teaches us that kind of empathy with another person. It's a kind of empathy practice to read a story, in a sense, to enter life. Shelley, the poet, the 19th century poet, called reading poetry, he said, strengthens the empathy muscle.
Which I like muscle?
We have an empathy muscle.
Seen that one?
In medical schools, however, in our medical school in Kansas City and also in Boston, we spend a month in some of the courses I teach, 6 months at a time, where we read classic literature, particularly shorter works, a few novels here and there, because the medical professionals are, as you can hear from Docia's life, are very short on time. But we'll read works by Toni Morrison, Chekhov, Kafka, Virginia Woolf. We've read this last year. We read the play Wit, and we read these stories, as a way of learning about what it's like to go through a difficult time. Each one of these stories shows a family or a person embedded in a family going through a difficult time and having to make a difficult moral choice. And I think what we're relying on in some ways is this concept that a great literary critic, a Proust scholar, Roger Shattuck, put it this way. He said, whenever, he said reading, I think the way he put it, reading can become the second beat in a two-beat process. He says when we read something about a new experience, we gain some experience, we gain an understanding of what that experience is at somewhat of a distance, but we gain it. And then he said when we come upon it in our own lives, in real life, it's that second beat where we say, I've been here before. I know this. And so it can become a way of practicing for an event that we may not experience maybe ever in our own lives personally, or certainly when our medical students and our physicians are on the wards, they then experience on the wards. For instance, reading a short story by Lori Moore or Raymond Carver or Kenzaburo Oe about what it's like to lose a child, and then on your fourth-year rotation in the pediatric hospital, experiencing for the first time with a set of parents the death of their child. I've had so many students and physicians say they had that two-beat experience of, yes, this is it. So that's strengthening that empathy muscle, but also gaining a kind of experience about entering someone else's life.
Yeah, Docia, I was wondering, now talking about this empathy muscle, do you think the physicians, in your experience, have strong empathy muscles? Does that come naturally?
It comes with the person.
It comes with the person. Tell us more about that.
It's the person. Everybody who knows me knows I'm a toucher.
I can tell. Yeah.
I tell my residents, it's okay if that's the kind of person you are to touch. There are a lot. I hug my parents when things are. I go up to them, and it's one of those things. I still remember this huge man going out the door, and he's standing next to his baby who's sick, and I think he's going to hit the floor. He's about 6'5", and I'm holding him up, and it's okay, and he's got his arm around me, and we're sitting there talking, and that's what you have to do for your parents. If I can tell, I always remember, you can tell how far back, I graduated from med school in '75. We had started in our senior year getting an ethics class, and one of our pediatric hematologists taught it. And he said he had been doing, and in that time frame, kids with cancer, a lot died. He said, I never understood what it was like until he said, I nearly lost my wife. His wife had a serious illness.
That must be the second beat, Marcia.
Yeah, and he said, you will never understand this till you have this happen in your life. And you have to lose someone close to you. And I've lost both my parents. And I had to, my mother, something went on, and I had to be the one to tell her she had cancer. And it was, that always sticks in my mind. And I want to be sure I tell my parents in a way that I would have wanted the doctors to have told my mother, and which did not happen.
The doctors didn't tell you?
No, the residents walked out of the room, said something to the effect, Miss Hickey, we're going to have the doctors who do radiation and chemotherapy come talk to you. Leave a fourth-year medical student sitting in the room with her mother. And I remember to this day her sitting on the john, me sitting on the edge of the shower in a semi-private room because there was no privacy in the bathroom, telling your mother she's going to die because she made me tell her. And that's the experience I do not want my parents to have.
Martha, you know, our time is kind of short now, but I'd really like to know if there's some sort of message you'd really like to convey to people about the kind of work you do and how you handle it. Or why you do it.
Oh, well, I wasn't even thinking. I do it. Why do I do it? I think Docia might say the same thing, because I love it. I think one of the things that's so amazing about it is constantly learning from other people about their lives, about what it means to live a good life, which, you know, is what we're all trying to do. But what does it mean to live a good life in the face of loss, which is the truth of all of our lives? And I think that the thing that I've learned a couple of things from parents and children and my colleagues that I've worked with. And one of them is, I think, the fact that the importance of remembering that no two people are alike, no two families are alike, and that when you're listening to people about their lives, helping them make difficult moral decisions in the face of tragedy and loss, to remember the uniqueness of the lives, and that listening is so powerfully important. And the other thing that I've learned over time that's become very helpful and very useful is, and Docia's stories make me think of it, the power of presence, of really being there for another person, whether it's to hold them up physically, but to really be there, and the enormous power that has.
Yeah, Docia, I'd really like your perspective too, your take-home message to this audience, because many people listening will be expectant parents or parents wondering how things are going to go. Do you have any messages of encouragement, reassurance?
Reassurance is that the majority of pregnancies go well.
Yes.
The majority of babies go home. They go home to a happy family, and things are the way they should be. Also, a lot of the children who come through our unit are fine. That's the joy.
Fragile children.
Yeah, even our fragile children. That's the joy of what we do, is when they bring them back and let us see them when they're 4, 5, 6. Yeah. I just had one child, I've got kids who are graduating from high school and things like that, and are now having children of their own. That's the kind of things that make my life worthwhile. But I've always tell everyone, the day it stops bothering me, when someone dies, the day a baby dies and I don't cry, I walk out of that unit.
Oh,
I mean,
wow.
I do, because that's what you've got to be able to, you have to be able to feel for your parents.
Well, what's so remarkable about both of you is it's kind of like a seamless web. You have reinforced each other. One of you from the world of science and medicine, the other one of you from the world of literature and poetry. And actually, you're both saying the same thing, that what gives you the possibility to serve people in these conditions is very strong empathy muscles. And empathy muscles gained through literature, through listening, through attending to people's differences. And you, from being on the front line and using your skills to help people come through these types of situations. I applaud you both because I understand what a difficult yet very rewarding lives you must have. So thank you, and thanks to Martha for coming from all the way from Kansas, and thank you for coming here to the campus where, all construction is making things difficult, and we're happy to have had you.